Good morning and welcome to this Eastern Region Safeguarding Adult Board 2021-22 seminar series. Thank you very much for joining us today, and I'm extremely pleased to welcome for us today Dr Jeremy Dixon from the University of Bath. I'll introduce Dr Dixon in a few moments. We have again lots of interest in this seminar today, looking at supporting people living with dementia to be involved in adult safeguarding inquiry, a really topical and important issue for all of us working within adult safeguarding. We have over 150 colleagues registered for the webinar today, which is excellent and really positive. Just a couple of quick pieces of housekeeping for you. Dr Dixon will be presenting his work on supporting people living with dementia and involving them in safeguarding inquiry for about 30 to 40 minutes or so. And then we'll have an opportunity to pick up questions or comments that you can put into the chat box. So as we're going through, please sort of put those thoughts or questions into the chat box, and we'll try and pick up as many as we can towards the end of the webinar. The webinar is scheduled to finish at around at 11:30, but it might be that we finish a bit early today. Just really depends. So after today, the slides will be available, and an opportunity for you to share those with colleagues who perhaps haven't been able to join us today. I'm now just, as I say, very grateful to Dr Dixon for joining us today and supporting us with this webinar. He's the Senior Lecturer in Social Work at the University of Bath. He has several research interests, including how professionals and service users understand risk, service users and carers' perspectives on mental health services, and mental health law. Dr Dixon is currently the Vice President of the International Sociological Society's Research Committee on Sociology of Health and Illness. So comes with an extremely developed and a great understanding of these subjects, and in particular most relevant to us working in safeguarding as well. So without further ado, and my thanks to you for joining us, I'm going to pass over to you now, Jeremy, to share your presentation. Thank you.
Okay, thank you very much, Walter, for that very generous introduction. I hope I can live up to it. So I'm, as Walter mentioned, my name's Jeremy Dixon. I'm from the University of Bath, and I'm a social work academic. So in this presentation this morning, I'm going to be talking to you about some guidance which I wrote for the Department of Health and Social Care for the Chief Social Worker in Adults office. So I'll give an overview of what I'm going to talk about, and it would be really good to have people's comments about what I'm speaking about, and just to get your view as practitioners. So a quick overview of what I'll talk about for the next half hour or so. So I'm going to talk about the background to this report, why we felt it was important to write, and then I'm going to talk about the two elements of the report itself. So the report is split up into two bits. So in the first bit of the report, I try and give an overview of the research about the level of abuse and neglect that people living with dementia experience. I also focus on how they interpret risk and legal frameworks. So when writing this guidance, I'm aware that academic journals can be quite off-putting to people, particularly when you're quite time poor as a practitioner. So I've tried to sort of write it in a jargon-free language as much as is possible. And the second part of the report is giving suggestions for practice. And these suggestions aren't just from me, they're coming from people living with dementia and also from practitioners themselves. So I've got a lot of advice from people in the field about what might be useful and suggestions, and my job really was to try and pull them together into something which was coherent and usable. So let's begin by talking about the background and why the report was written in the first place. So the report came about really because I was doing a bit of policy work at the Department of Health and Social Care in the mental health unit a few years ago, and they introduced me to Limro Mayo and organised a meeting. So we talked about issues which might be of interest to people who are working in the area, and safeguarding, as you will know, it has become a key area for the Chief Social Worker for Adults. And so this was one thing which she thought practitioners might be interested in. I was starting to do some research in this area and was just starting to look at the evidence really. And the evidence shows us that people living with dementia are at greater risk of abuse and neglect than those people who do not have a diagnosis. And so this first reference I put up here is from an international literature review by Fang and Yan, and they look at the evidence worldwide. And although there's more research evidence in some countries than others, this does seem to be an international phenomenon, and there does seem to be evidence that abuse is much greater in this group, both in the community and in care environments. So what do we know about this from the stats in England? Well, as I'm sure most of you will be aware, there's an annual safeguarding return, and the government pulls the figures together to give a view about the amount of safeguarding referrals which are received and the amount of safeguarding inquiries. They don't collect details about people living with dementia specifically, but if we look at the figures, we can see that 1 in 43 adults who are aged 85 and over has been subject to a safeguarding inquiry. So of course we don't know whether these people have dementia, but we do know that people in this age group are at quite a high risk of having dementia. And if we compare that to people who are adults of working age, we can see that the referral rate is much higher, so over 16 times higher than for that group. So there are some graphs that you can look at, and there's quite a noticeable difference. They're quite hard to sort of take off and put on a slide, unfortunately, but if you want to have a look at those yourself, I've put the reference at the end, which I'll circulate to Walter to give to people. So how did we go about doing this guidance? So I mean, I'm an academic, so obviously I'm good at sort of finding things on paper and sort of pulling them together, or that's my job at least. But I wanted it to be of value to practitioners and the public, and so I did a number of consultations, So Lynn Romeo's put me in touch, first of all, with a national group called Think Local Act Personal. So you may be aware that this is a group which campaigns on the personalisation of services, and I presented to a group of people who had interest in this area, and I presented to both carers and users of services. So the carers there had got experience of caring for people living with dementia. The service users were from different groups, but were speaking more about personalisation. So what I did with this group and other groups was I presented what we knew already about the issue at hand, and a bit about the research so far. And then I asked for people's ideas really about, well, you know, what do you think we should do about it? Which is what I present in the second part of the report. So I also spoke to something called the Margaret Butterworth Forum. So this was a forum which is run by King's College in London, King's College London rather, and it's a group which is made up of people who are interested in care for people with dementia in care homes and nursing homes. And so this is attended by practitioners, but also, you know, quite a lot of carers as well. So I presented there and got feedback, and I also got in contact with the Alzheimer's Society nationally, and they put me in touch with a couple of local groups. So I got input from people living with dementia throughout that process. In addition to that, as I was writing the guidance, I got some very helpful feedback from practitioners. So I had contact from the safeguarding lead at ADAS, the Association of Directors of Adult Social Services, and also a number of people on the Principal Social Workers network. So I sent various drafts of the guidance which we were putting together to them, and they were helpful enough to point out things which might be problematic and give some suggestions about how that might be improved. So in the next part, I'm just going to talk about the evidence as it stands. So this forms the first part of the report. So the report is available online and it's free to access, and Walter has kindly agreed to send a link through, sending it to you afterwards. In addition to this, I'm drawing on some work I did for an article which was published in the British Journal of Social Work. So this is an open access article, meaning it's available for free, and Walter's also going to send that out to people. In the article, I go into a bit more detail about some of the knotty problems that we find ourselves in, and the article was written a bit later, so I had the benefit of a peer review where you send it, where other academics look at it and sort of try and pick holes in your arguments, which helps you to sort of come up with something stronger. So I've drawn on some of the thinking there as well. So let's begin by thinking about what we know so far about the experience of people living with dementia. So, as I mentioned, there's a lot of international research, but I'm focusing here on research studies in the UK because obviously that will be of interest to those of you attending today. So, UK studies tend to report high amounts of abuse in the community, but I want to add a bit of a proviso to that. I would say that the research which has been conducted is still at an early stage, and there are some limitations with the methods which have been used. I mean, there's always limitations with people's methods, but it's important to understand what they are. So the studies which tend to have been done have largely been done with carers, and they rely on self-reports from those carers. So the study by Cooney in 2006 looked at carers' self-reports about whether they've been abusive, and the same occurred for the later report by Cooper. So in Cooney's report, 51% of carers reported verbal aggression towards the person that they were caring for. 20% reported physical abuse and 4% neglect. The later study, that the figures didn't seem to be that high. So in the Cooper study, verbal abuse was reported at 33%, and only 4% of carers were reporting physical abuse. So the authors of these reports note that these figures may be underestimates because people may not wish to own up to being abusive. The study, which was done by Samsey et al., was speaking to people who ran Alzheimer's Society groups, and were asking people if they were aware of incidences where people had experienced financial abuse, and the group leaders would say that that was relatively high. So moving on to the second bit here, so studies in care homes. So early studies have been which have looked at the experiences of people living with dementia. They're quite small scale, so we've got to treat the results fairly cautiously. But the study that was done by Cooper found that 8.3% of carers reported threatening residents, avoiding them, or not giving them enough food. And the report also found that people often weren't going out of their way to be abusive, but often care workers didn't know how to respond to people in positive ways, and so were doing things which were maybe inadvertently abusive. A larger study has been done in 2018 by the same author. So this study isn't looking at people living with dementia specifically, but is looking at care home practice for older people. And they asked staff how often they had seen or reported abuse, and 51% of staff said that they'd observed or reported elder abuse in the last 3 months. So whilst this isn't focusing specifically on people with dementia, we know from estimates which have been done by the Alzheimer's Society that around 69% of people who live in care homes are likely to have dementia. The type of abuse which was reported here is seeing a resident being made to wait for care, which occurred in 25% of cases. In other cases, 25% of people reported seeing others avoiding people with challenging behaviours, and 19% of people reporting abuse were saying that people hadn't been given enough time to eat, and 11% of cases there was reports of people not taking enough care when moving people who were older in these environments. So the studies generally tend to show that levels of abuse and neglect are higher when people are perceived to be exhibiting challenging behaviours or are irritable or seen to be resistant to care. Abuse is also more likely in a community where carers are experiencing anxiety or depression. So the next bit of the evidence review looks at perspectives on risk, and this is one of my areas of interest. And I wanted to look at this because quite often we talk about risk as professionals and we see that as a common sense term, but often we don't really unpick whether people understand the language that we're using, or look at how other people interpret those terms. So there has been some guidance given by government about how professionals should manage risk. So there was guidance by the Department of Health in 2007, best practice in managing risk. And there's also some dementia-specific guidance written by Manthorpe and Moriarty, which is a really nice piece of work, which is useful to look at and gives some good practice examples and case examples. So both of these documents say that professionals should aim to be collaborative in the way in which they work with service users, and that they should avoid defensive risk taking and try and take what academics often call positive risks, meaning that you take risks which might improve the quality of life for the person more generally. Allowing people, well, to give an example, an example of defensive risk taking in a care home might be sort of locking the doors and not letting people out, and an example of positive risk taking might be letting people out in the garden freely, which might mean that people are more likely to slip and fall, but the positives which people are likely to experience would outweigh the negatives. So research which has been done with people living with dementia shows that people are aware of hazards and dangers which they might experience. So the types of things that people talked about in research is the possibility of financial scams, things like not turning off the hob, the risks that they might have through driving. But the research also found that people living with dementia don't really use the word risk, so that word may be alien to them. They tend to, think about things like danger when they're talking about things themselves. So if you're using the term risk, then you have to be careful to explain it to people and be clear about what you're talking about. Family carers do tend to talk about the issue of risk, and whilst they're aware of it, they're quite keen that professionals aren't too defensive in their practice, so that the quality of life of their relatives isn't sort of negatively affected. Interviews with professionals has shown that professionals are highly aware of risks. So as professionals, it's quite natural for us to be a bit worried that we're going to be blamed for things that go wrong if a risk has been missed or we haven't been seen to assess it properly. And early studies of risk behaviour tended to show that people, professionals were quite defensive. The later studies are showing a more positive picture and are seeing that professionals understand the need to engage in positive risk taking. So one participant in this study by Stevens and Taylor said, "I think the focus has been on taking positive risks, whereas before, when you did risk assessment, it was, oh, we've got to stop this, we've got to stop that. But now it's about how do we enable people to do this and to keep as safe as possible." But these research studies show that agency culture is quite important. So staff are more likely to engage in positive risk taking if their agency backs them up if something goes wrong. If they feel they're going to get blamed by their agency, then they're much more likely to be defensive, perhaps unsurprisingly. So the other thing that I focused on a bit in the guidance, but much more in the article, is the issue of human rights. So Geraldine Boyle has been writing for some time that people with dementia, their human rights are often neglected due to erroneous assumptions that people with dementia lack capacity, altogether. And since the Mental Capacity Act, hopefully people are more aware that capacity is decision specific, and that we can't assume that people don't have capacity, that there's a legal duty for us to assume capacity and check that out. Check out particular instances where we think that there might not be. But thankfully, there has been much more of an emphasis on protecting the human rights of people living with dementia. So the British Institute of Human Rights has written a useful piece of guidance, which is quite reader friendly and practitioner focused, which is talking about ways in which we might use the Human Rights Act. But there's also been more academic debate and debate by the disability community about how we might use the UN Convention for the Rights of Persons with Disabilities, known as the UNCRPD for short. So it's worth just saying a little bit about the UN Convention, because I think this is the way that things are starting to head. So the UN Convention is seen to guarantee rights for people living with disabilities, and the dementia advocacy groups internationally are sort of pressing for dementia to be seen as a disability, so that people living with dementia can be guaranteed those rights. The UN Convention is something which the UK signs up to, and we've signed up to something called the optional protocols, which means that our legislation is supposed to align. There are some problems with this. So the UN can come and inspect us and say that they feel that we're lacking, which they have done in actual fact. And the government just has to give a response and say, well, we think we're doing it, and there's no real action that can be taken to enforce it after that time. However, it does have some validity still, because if you look at case law decisions, you find that judges are starting to draw on the UN Convention when thinking about human rights and how they ought to be protected. And the reason why it's useful is it's seen to guarantee what's known as positive rights, so the things which, or services which people should be offered, which is slightly different from the way in which the Human Rights Act operates. So I won't go into too much of that sort of technical detail now, but I can cover that a bit more if people want to ask the question. So in the guidance that I wrote for the Department of Health and Social Care, I didn't get into these arguments so much, but I did set out these principles by Butchard and Kinderman. So Butchard and Kinderman try and pull together all these different human rights frameworks that we have and put it into this acronym, which is hopefully easier to remember. So human rights laws can be a bit baffling, but it can be useful to remember these key elements here when going about our sort of daily work. So there's various subsections for each of these. I'm not going to read all of them out because it's a big list, but they give it in a sort of person-centered form. So for example, for fairness, they say here, do not make assumptions about me, give me time and space, and do not exclude me because of my dementia. And there's subheadings for each of those, and in the guidance I've listed those in detail, but I won't read it, otherwise that just tends to sort of send people to sleep if you're reading a big list online. Okay, so the next bit of the evidence summary is talking about strengths-based approaches. So here I draw on Salibi, which you might remember from your training. So strengths-based work is a theory which is often used in social work practice. So essentially, we need to think about ways in which we can identify the capabilities of people and look at using supported decision making to help them to make as many decisions as possible. And several practice resources have been developed by the local government association, and I make some links to those in the reference list to the guidance, and through the Making Safeguarding Personal online apps, a lot of those are available and are fairly easy to sort of access and use. So things like the Signs of Safety and Wellbeing Practice Framework are helpful here. So strengths-based frameworks are useful and can be used creatively. So people like Manthorpe and Iliffe has suggested that there's certain things we should be thinking about. So we should be thinking about maybe the interaction between things like gender, sexuality and ethnicity, you know, whether there's different ways that people might be discriminated against and how we address that. The relationship between a person's mental ill health and physical disabilities might be something we need to consider. How people's social relationships shape the type of support they receive and their social networks such as family and friends. We also need to think about the person's economic status and how factors like housing have an impact, and how effects like things like migration and language may affect persons. So all those things, as we know as social workers, might have an impact on people. So our job as social workers is to try and think about those things and think about what supports we can put in place. So to try and challenge ways of thinking where we just think about it individualistically. So in the guidance, I also talk about the legal frameworks here. I mean, I won't go into these in so much detail because I'm assuming that as social workers, this is your sort of area of strength, really. But for those of people who may not be aware, other professionals engaged in safeguarding, we've set out the Section 42 criteria, the principles and the code of practice around safeguarding in the Care Act guidance on this issue. And we've also set out the 5 key principles of the Mental Capacity Act and the things that you'll be well aware of. So the need to assume capacity, and capacity being decision specific. I've also talked here about supported decision making. So this is something which has really been pushed through the UN Convention on the Rights of Persons with Disabilities, and there's some good suggestions which are coming out internationally about ways in which we might support people. Advocacy, of course, is very important and can be offered in specific circumstances under the Care Act, the Mental Capacity Act and the Mental Health Act. I mean, there are some problems with that, which I've explored in a different article, but I'll save that discussion for a different time. So moving on to the second bit of the guidance, where we talk about what good practice might look like. So some of these things sound quite sort of common sense-ish, but what we've tried to do is to provide some sort of decision guides or decision aids that you can use in your practice, and all these things that aim to be helpful. So they're not supposed to be a list of things that you must go through from, you know, stage by stage. The idea is that people can use and adapt them as they find them to be helpful. So the first thing that we've identified is the need to provide clear information about safeguarding. So what was interesting when I was doing this piece of guidance was I looked online to see what information I could find publicly, And some local authorities do this really well, but with other local authorities, if you look to see their sort of statement on safeguarding, it's very hard to find, or if it is there, it's not very accessible. It's, you know, all the sort of section 42 stuff, which wouldn't necessarily be that understandable just to a member of the public, you know, looking at it. So there's a need to provide clear information. And interestingly, when I went to present to groups of people who were living with dementia, most of them, you know, had no idea what safeguarding was, and also with the carers actually. So with those groups, I was having to sort of start from scratch and saying, well, this is what it is, you know, this is what the legal responsibility is. So most people don't know, and I think there's an interesting piece of research to be done here potentially about, you know, what the public does know about safeguarding. So we do need good information which is public facing, easy to understand, and people living with dementia were saying, well, it would be really useful if people could come and present to us, or, you know, talk to us in things like dementia cafes or in those kinds of forums, so we have a key idea of what it is and what we might do about it. Of course, when people are referred, then we have a duty to explain what safeguarding means to them at a personal level, and I'm sure you've you know, got some experience of doing that. But there is a need to try and build up a good relationship with people, and the kinds of comments people living with dementia were coming out with was, well, actually, I'd find it all a bit much if people tried to do it over one session. So people were identifying a need to split it up. And I'm aware that resources are very stretched and this can be difficult, but there are some examples of safeguarding adults boards extending, you know, the deadlines to enable practitioners in their areas to do that. And there's some examples in London which I talk about a bit more in the safeguarding article that I'm going to talk about. So the other thing is talking about people in their environment. So as I mentioned, people identified the need to break down information, and the research evidence about how you best communicate with people, I would say, is really a bit sketchy. But what we know, I suppose, is that people feel more able to engage with decision making if they feel that practitioners are engaging with them in a collaborative way. They also cope better if they're in a quiet room with not too many interruptions or distractions. And another point is that, you know, having lots of people in a room can be quite confusing to people living with dementia, and often that's something that we forget when we're doing case conferences. You know, you often have, you know, huge amounts of people, so there may be a case for, you know, splitting that up and having conversations individually, at least before the meeting, so that people can think of that. Thinking about the type of dementia that people may experience is important. There's some good information which was published by the Chief Social Worker's Office a few years ago, which gives some clear guidance on the types of dementia and how they affect people. We also need to think about the common sense things which we often think about with capacity, like time of day, and also some of the common sense things that is quite easy to forget, like whether people have a hearing impairment, a visual impairment, and also cultural issues around things like culture, or ethnicity or sexuality. So with the culture issues, if you look at the research, there's some evidence that some groups of people feel that dementia is quite stigmatizing. So some research has been done in my local area, trying to encourage the Chinese community to engage with services more readily, because they're a group who tend to be more afraid of mental health services and support. And there's also some evidence that lesbian and gay people are quite anxious about revealing that they may have dementia because they're worried about the type of support that they may receive in nursing and care homes. So we need to sort of be mindful of those kinds of things when we're approaching people. So in terms of the support, we've talked about things like considering advocacy, and a large part of the practice guidance talks about decision guides. So I can't really put these on the slides because they're a bit too big to put on in a way which is readable. But this is really the sort of meat of the guidance, and is something which I encourage you to have a look at. So some of these things have been used before and are available through the LGA website. So there's some good decision guides which identify the strengths of people, what people are good at, and how we can support them. But when I was writing the guidance, one thing that a practitioner mentioned to me in one of the London sessions was that quite a lot of work had been done around supported decision making in Canada. And in Canada, a lot of supported decision making tools are being developed, mainly for people with learning disabilities. And essentially what these tools do is provide graphs where you try and break down the information into manageable chunks. And this seemed a useful thing to do because the people living with dementia who we spoke to were saying, well, I find it all a bit too much to take on board. I need it splitting up. So what we've tried to do is to identify ways in which you might put forward to people a number of different options and weigh up the pros and cons. So in the guidance, I've tried to provide some case studies where people might be experiencing abuse and neglect. And I've given a fictional case study, and then I've tried to sort of, identify, well, here's a way in which you might weigh up the options of helping someone who might be experiencing financial abuse. And we all know that people who have capacity have the right to make unwise decisions, but we really need to be careful that we don't just leave it there, and that we help people to break down things and to identify the pros and cons of different decisions that they may make. And then, of course, people are free to decide what they wish if they have the capacity to do so. So lastly, of course, it's important to review practice and to make those findings known to people. The people who we spoke to who were living with dementia were saying, well, yes, it's useful to have a written document, but it would be helpful if people could be creative about the ways in which they went about that. So some people are saying, I'd like to have a postcard which, sums it up that I could keep on the fridge. Other people are saying it'd be quite nice if somebody could record a very brief summary of it so I can sort of listen back to it and remind myself of it. With all these things, of course, social work's very complicated, so you do have to, bear in mind, is an abuser likely to look at it and those kinds of things. But these are things to consider, and hopefully these suggestions are helpful. So I think I've talked for about 40 minutes now. So just a brief summary. We've talked about the guidance and what it offers. So from the research summary, we know that people in the community and in care homes do seem to be at greater risk of abuse and neglect than other people who don't have dementia. We need to be careful about the concept of risk when we're talking about it, because it's a professional sort of jargon term that we use quite freely, but often other people don't know what we're talking about. So we have to unpick that a bit. And there's a lot of new guidance which is talking about how we support the human rights of people living with dementia. So it's useful to engage with that, and I think that's a positive thing. Suggestions for practice. We need to think about how we're providing information about safeguarding, both at a population level, to members of the public generally, and also to individuals. And then when we're doing safeguarding work, we need to think about the person's communication needs. And I've talked about all those individual things, so I won't repeat them here. We need to think about what's important to the person and where the conversation's held. People who we spoke to who had dementia thought it was very important to build a relationship, and also using decision aids is something which is maybe a bit underused in social work, and is something which this guidance aims to address. So thank you very much for your attention. I know it's always difficult doing these things online. It's much easier, isn't it, when you can sort of see people and speak face to face, but the good thing about this is that I can speak to quite a lot of you. So I'm going to hand over to Walter as the chair in a minute, but before I do, I'll just say that I've put the references up to the literature that I've sort of referred to here in case people want to have a look at it. And in addition to that, the two things that I've been drawing on here is the guidance which is published by the Department of Health and Social Care. And as I've said, I've tried to sort of keep that in plain English as much as possible. So hopefully that should be not too difficult to get your head around and to read. And if you're interested in more of the sort of fine detail of the human rights arguments on this subject, there's an article that I've written with other academics in the British Journal of Social Work, and that's also free to access. So I'd be really grateful if you could let other people know about this guidance. I'd be interested to hear about, you know, whether you find it useful or not, or things that you feel maybe could be improved with it. And I'd be very grateful if you could sort of spread the word and to sort of publicise these things by Twitter and those kinds of things, or just to send it out to people you know. Often when you write things, you sort of worry as an academic, it just sort of stays on a shelf and nobody looks at it. So it's would be really helpful if you could put it out, and please do let me know if it's helpful. So I'll turn my presentation off now for now and hand over to Walter.
Jeremy, thank you so much. I mean, that was really insightful and informative, and touched on so many important areas of our work in safeguarding and working with people to protect them. So thank you. And indeed, we have, I'm sure, a lot to take away from the work you've done and weave it into our practice. Colleagues, we do now have a bit of time to pick up specific questions or comments for further reflection or thinking around before we finish today. Jeremy, perhaps I'll start with this. Amanda, thank you for your comment in the chat box, which I think is very interesting, Jeremy, because Amanda has done some work within the Eastern region. She says, looking at the domestic homicide review reports and also safeguarding adult reviews, where the victim had additional sort of vulnerabilities, some of which were around dementia, but there are many others. And Amanda makes a really interesting point that perhaps you'd offer a few thoughts on around risk. She picks up that risk, as you said, is a huge issue, particularly where practitioners may be working with risk in perhaps a rather a siloed way rather than a combined way. And how might we support? So my question really, from what Amanda has said there, is how might we best support practitioners to expand their thinking around risk, rather than just thinking of risks on their own, so drawing in other aspects like age, dementia, abuse, other factors that you've mentioned. I mean, any thoughts there?
Yeah, yes. So I think this sounds like obvious advice, but I think it's the research shows that it often isn't done. So I think the most important thing around risk and risk assessment is that that's shared with the people that you're working with. So I started off being interested in research because I worked with offenders with mental health problems in a forensic unit for a number of years, One thing I noticed in that environment was that we talked about risk all the time. So we'd have these long involved questions about, discussions about what the risk is, is the risk high or low? Has it gone up and down? And then when we had, ward rounds or care management meetings, often people would, not go into the risk assessment with people. So they tend to be a bit nervous about it. So you'd have these conversations where practitioners say, oh, you're doing really well, then that issue would be avoided. And often that was because I think people were worried that risk would be an upsetting thing to the people that they were talking to, or that somebody else would do it. And it's really important, I think, that if risk assessments are done, that somebody takes the time to go through it with people and looks at what their view is and how it can be explored. So, I mean, there is some good literature by somebody called Chris Deering, spelled D-E-E-R-I-N-G, at the University of the West of England. He's done a good piece on what service users think is helpful in relation to risk practices, and that draws together a lot of the research which has been done elsewhere, and identifies positive ways of talking about risk to service users. I hope that answers your question, Walter and Amanda.
No, indeed. I think it's indeed. I don't think that it's not a sort of a one-off sort of question that will answer that will help us sort of address this. I think it's really valuable. I mean, this is going to be ongoing, I hope, reflection and thought for colleagues on the call today. Something, if I may, that caught my ear, Jeremy, was that point you made around involving those living with dementia and their families. In the work that you did, was there any consideration around where there are concerns that the potential perpetrator of abuse was within the family? And we know something of that, don't we, from research, where you are more likely to experience abuse from someone you know, than someone you don't. And did the work you've done and the guidance you've developed sort of give any thoughts or commentary on that, issues around family members as potential perpetrators, where the person's got dementia, so they may be dependent clearly on their support and help?
Yeah, I mean, we covered that a bit. I mean, there's no really easy answers to this. It's a very complicated issue, I suppose. I mean, I think what we say in the guidance really is that, and also in the article, that we do need to be aware, I suppose, that people living with dementia often rely on the support of informal carers to make their views known. So a lot of research about how people living with dementia communicate says that they rely on carers to give them prompts and to orientate them in the conversation, as it were. Where that person is the abuser, then it becomes very tricky, of course. So, I mean, I think that what you would have to try and do as far as possible in those situations is to try and involve somebody else who might know the person, or if that's not possible, to engage with statutory advocacy services.
I'm not sure whether we might have perhaps.
It looks like I got locked out then for a second, but yeah, I don't know how much of that you heard.
I think we perhaps lost the last few sentences, perhaps, Jeremy, perhaps to repeat.
Okay, so I think I was saying if there are cases where people who are living with dementia are experiencing abuse from a family member, or that is a suspicion, then I think all you can do in those situations is try to involve other people who know the person, if that's possible, or to use statutory advocacy services to support the person. But of course, it's very complicated and there's no easy answers to these dilemmas in practice. And I was also saying, I think that the research around, who abuses and in what circumstances, it's still pretty sketchy at the moment. So we don't have a very good picture of that. There's maybe a handful of studies still, and they're mainly based on self-reports from carers themselves, as I mentioned before.
Thank you. Please do, colleagues, if you have any questions, or they don't have to be detailed. They could be a very quick or straightforward thing you'd like to ask. Jeremy, please pop that in the chat box as you can, as we're going through. Another question here I've got, actually, Jeremy, is interesting, is to thinking about those responsibilities that safeguarding practitioners have around making safeguarding personal, and its interface here with those living with dementia, and some of the things you've said from the work you've done.
Walter, your sound's gone off, unfortunately.
I hope, can you still...
Yeah, I can hear you again now, yeah.
Yeah. Right, okay. I was just saying, interested in any thoughts you may have around making safeguarding personal, MSP, a sort of role, an aspect of our practice within adult safeguarding, about involving the person and looking at the outcomes that they wish to achieve. Did anything like that emerge from the work you did, or the contacts you had with those support groups?
Yes, it did. So, I mean, as I mentioned, I spoke to people from ADAS, and also I spoke to people from the local government association, who's published quite a lot on, as you know, on making safeguarding personal. So, I mean, they were very helpful in identifying some of the resources which are out there for practitioners to use. So I've tried to sort of weave them in as much as possible, and also to some useful books which have been written by practitioners about ways in which they've engaged in safeguarding, and helpful ways of sort of managing risk and so forth. So some of the tools which are used in the guidance draw on some of the making safeguarding personal tools and resources as well. So we've tried to weave that in as much as possible.
Thank you, Jeremy. I'll pick up this next question. Unfortunately, I don't know who it's from, and it is Jeremy, do you have any thoughts about how the pandemic has impacted on practice in supporting people with dementia in safeguarding inquiry? Any thoughts about how we might remedy this impact? That's a very important question there. Thank you.
Yeah, no, that is an important question. I mean, it wasn't something that we dealt with in this guidance, because we did the guidance before COVID, and there was a bit of a delay of it coming out because the Department of Health and Social Care were obviously prioritising COVID stuff. So people didn't talk about that really when we were doing the consultation. I mean, so I don't have a great deal to say, and I guess as practitioners, you'd probably have more experience of this than me. But obviously, I mean, what we know about things like domestic violence, research that's coming out at the moment tends to suggest that domestic abuse and violence has increased over the period of COVID, because people are locked in together, and obviously there's a lot more pressures on families, and services that haven't been as easily available. So yeah, I don't really have any sort of concrete suggestions to give, but I think that I mean, my first thoughts are that it's going to be important to try and get communication to people and to see people face to face as much as possible, rather than doing things remotely, because as we know from practice, it's quite easy to miss some of the cues if we're seeing people in that way.
Thank you, Jeremy. I mean, indeed, I mean, practitioners' services are working in very many different ways, aren't they, through the sort of the pandemic and the lockdown. And while there is some really excellent examples of proactive and protective, support to people at risk of abuse and harm, sometimes, yes, being in the room or in the moment with someone is equally difficult. I think you're right, if I may, that there's no sort of clear or straightforward answer to that question about the impact of the pandemic on people living with dementia, specific to safeguarding inquiry. And I think it's something that we should all perhaps continue to keep on our radar, and see how that develops.
Actually, it just reminded me, there is a study, I think some researchers are looking at this issue specifically. I don't think they've done the research yet, though, so I think this research is still in progress, and I can't remember where they're from actually even, but I've got it written down somewhere, so I could send you the answer to that one later on about who's doing it. I think they have got a project website which you can look at, and I'm sure that they'll put the results up once they become available.
No, thank you. That would be really helpful to share with colleagues. Encourage you to sort of take a moment to look at that, because, as I said, I think this is a really important area for those within sort of adult safeguarding practice and working with safeguarding boards and other partner agencies. Another question, if I may, here, Jeremy, you touched on in your presentation about positive risk taking, and you picked up the point around those organisations with strong positive cultures. Now, in supporting practitioners sort of do that, and enabling practitioners to work in a way where that is developed and encouraged. I appreciate this might not have been something specific that the guidance, that the work you've done touched on, but any thoughts about, particularly for those people living with dementia, how organisations, what are there one or two approaches that we can support and develop around positive cultures in this regard, to sort of embed that positive risk taking?
Okay, so I think from my previous work, which isn't necessarily related to this, I think that, as I mentioned before, it's important to be transparent about the risks that you're assessing with the people that you're working with. So, in other words, often risk assessments aren't shared, and service users aren't aware of what's in them in mental health. And this, my research with offenders with mental health problems found this, but this has also been found in other mental health settings by other researchers, such as Michael Coffey, somebody from Swansea, did some research which in general mental health, and also somebody called Joan Langham from Bristol quite a while ago who did this research. So that's been a recurrent thing. So first of all, I think sharing things is important, as I mentioned, but then in terms of agency practice, I think it's important for agencies to try and be evidence-based as far as possible. So I think a lot of risk assessments that you see aren't really based on any evidence. They're just a lot of sort of tick boxes that look a bit scientific, but aren't really based on any evidence. There are some tools which aim to encourage positive risk taking. So somebody called Brian Taylor at Ulster University has developed some tools which we used in Ireland, which have helped practitioners to think about positive risk taking from the point of view of the service user. So utilising those kind of things can be helpful. And I think the biggest thing really is in being supportive to staff where they are doing positive risk taking and it goes wrong. So if a risk happens and the management then come down on an individual practitioner like a ton of bricks, then that obviously puts people off being more proactive in their practice in the longer run. So management culture is very important to sort of keeping these things positive.
Thank you, Jeremy. Indeed, I mean, colleagues might. You mentioned work done by colleague Taylor in Ireland, and colleagues might be interested. This is also a live area of work that the Norfolk Safeguarding Adult Board is developing. We're working with some colleagues from the University of East Anglia to develop a tool that is around positive risk taking for those with dementia, perhaps looking more widely than just safeguarding inquiry, but it's something that we've recognised that and practitioners are talking to us as and myself as the board manager in Norfolk around the value of having some additional tools, but in tools that are informed by evidence and are a bit more clearly defined by what we know from the research evidence. So that's I'm interested. I'll follow that lead up myself, Jeremy, to that work done by Taylor, and sort of potentially feed that into the work we're doing, as I said, with colleagues from University of East Anglia. There's I think just a comment here in the chat box, which I think is also helpful to us. Talking a little while ago about sort of the impact of the pandemic, colleague has commented it was very difficult to maintain best practice within organisation pressures not to do face-to-face visits. I think that's absolutely important that we acknowledge that, and it has eased its course, but I wonder if the damage is already done, and I think that may well be the case, potentially the case, and the sort of some of the impacts and difficulties that we are moving through in terms of our safeguarding practice. And again, that might be a very valuable area for further research and collaboration to understand that impact. But I think that's an important comment a colleague has made around that the impact already happened, I suppose, Jeremy. Okay, there aren't any further questions that have been put into the chat box, but just before potentially we perhaps draw ourselves to a close, Jeremy, is there one practical thing that colleagues on the webinar today could do straight away within their practice, or supporting colleagues in working with people with dementia around safeguarding inquiry? What's the one practical thing you'd like them to take away from our webinar today?
So I'd like people really to consider using sort of decision aids. So they may not be useful in every circumstance. So I don't, not saying it's a cast iron rule that you should use it in every circumstance, but I think it is an interesting way of practicing which might help people living with dementia to better understand what's going on. So I'd encourage people to have a look at that part of the report particularly and consider, using those in your practice. I mean, you may want to adapt the templates that we've given, but yeah, I'd encourage people to think about that and maybe have a talk about whether that's useful. It would be really helpful to me if people wanted to say whether they find the guidance useful or not, and if people are using it in their practice, I'd really appreciate it if you let me know. As I mentioned before, part of the thing of being an academic is you worry that stuff can just remain in the library and isn't of any earthly use to anybody. So universities now are quite keen to see that we're engaging with the public. So if you could provide me with feedback on if you've used it, that would be really helpful. But yeah, well, thank you very much for inviting me today, Walter, and also thanks to Amy for managing the technical side of things so that we don't have to. So thanks, Amy.
Thank you, Jeremy, and I'll just reiterate that colleagues, we will circulate Jeremy's slides after the event, and there'll be a link, as he said, to that material. if you are using it at the moment, we would really like you to get in touch with Jeremy and share just that feedback on how you found it, its use and value in terms of your work. And if you haven't perhaps had a chance to look at it, please do so. Absolutely appreciate your diaries will be busy, but this is all about trying to improve and develop the things that we do to better affect the people that we are working with. Well, quick question perhaps, but just before we come to a close, Jeremy, can you give some more examples of the decision aids, please?
Yeah, I'll see if I can share the screen with you and then show you in the guidance. So there's a number of these decision aids in the guidance. So what we've done is we've split these into various blocks, but the first ones here is about thinking about the person's communication needs. So really they're just like checklists. So here it's the first one is type of dementia and the effects on communication, methods of communication a person prefers, times of day, preferred language, hearing and visual impairments, communication style or cultural needs. So these are the sorts of things we've picked up from research which are useful to consider, and then we've given some examples of how you might fill it in, just to give you a sense of that. We've also taken ones from the Making Safeguarding Personal tools about thinking about what's important to the person, which you could see here, and then again there's an example. And then the decision aids towards the end is given to highlight the alleged concern and what help or assistance a person found useful. And then we've tried to identify different options that people might have, the benefits and pros and cons basically of each option. And the idea of filling this in is just to help people to think about each option and to remember it. So again, there's a bit about support here, and then we've given some examples here of how you might use it with a case study thinking about financial abuse. So hopefully they'll speak for themselves when you have a look at it, but please do, yeah, to take a few minutes just to read it and see what you think.
Thank you, Jeremy. And the fact that the work you've done has got some worked examples within the guidance is, I think, really helpful as well. So you can just get a sense of its use, you know, its application. That looks really helpful. So colleagues, thank you for your time today to join this webinar. My thanks to you, Jeremy, for presenting on supporting people living with dementia and involving them in safeguarding inquiry. It's been really interesting, and hopefully there's a lot for people to take away and to share on to their colleagues as well. Just to say in closing then, my thanks to Howard and Amy and colleagues from the Suffolk Safeguarding Partnership for hosting the webinar today, and for hosting the webinars in the series, Eastern Region Safeguarding Adult Board webinar series. So thank you to them. This wouldn't have been possible without their support. So indeed, that's really helpful. Our next webinar, colleagues, will be taking place on the 8th of December, and we're looking at alcohol addiction and its interface with adult safeguarding. And that webinar is being led by Mike Ward from Alcohol Change UK. being chaired by colleagues from Hertfordshire Safeguarding Adult Board. So please do make a note in your diary. Hope you can join that one as well. And then into the new year, we've got Julie Smith coming to lead a webinar on from the Office of the Public Guardian, and that's 14th of January. We're hoping then that the March webinar will look at modern day slavery, but that's to be confirmed. So in closing, I just want to again thank you, Jeremy, for your time and support today in talking about a very important aspect of safeguarding adult practice. And for all those that have joined the webinar today, thank you. I hope you found it interesting and informative and giving you lots to take back into your work in supporting people, protecting people from abuse and harm. Many thanks, have a good day and goodbye.